I am so pleased to welcome Dr. Kupali here today. Thank you so much for being so generous of your time. I know you usually don't speak to groups this amateur compared to your usual professional association presentations, so we are very grateful. And I noticed in your name you have MD-FIDSA, and I looked that up, and that means you are a fellow in the Infectious Disease Society of America, which is not easy to get into. You have to be published in peer-reviewed paper if you recognize an expert in your field in infectious diseases. And that's what you do at UT Southwestern. I see you are in ID consults all the time. I'm guessing people are bringing you, I don't know about this. Is this an infectious disease? And you're the expert they go to. Am I right? And that keeps you pretty busy there, right? Well, Dr. Kupali, she's an associate professor in the Division of Infectious Diseases and the School of Public Health at UT Southwestern. Her work focuses on emerging pathogens, global health, and pandemic preparedness. She served as medical director of an Ebola treatment unit in Sierra Leone, which impresses me, and played key roles in the WHO, World Health Organization's response to COVID-19 and Mpox. She's advised governments, contributed to U.S. congressional hearings, and led initiatives for IDSA and ASTMH recognized globally. She is frequently cited in the media, was named NPR's Source of the Week and one of Elemental's 50 experts to trust in a pandemic. That's always good to know. Glad you're here. Thank you.
Thank you. Thank you for that kind introduction, and thank you for the invitation for having me today. So I'm going to talk about reimagining global health, and the information for my talk is really a lot taken from my personal experiences, not just working here in the United States, but working in other parts of the world, and really thinking about how we need to improve our preparedness for emerging threats, but also how we can just develop a more sustainable way to fund and do global health. Before I get started, these are my conflicts of interest. I work as a consultant for a CEPI-funded project on vaccine safety called SPEAK. I was a consultant for Gilead Pharmaceuticals on COVID-19 and prior WHO staff and consultant. The other thing that's really important is that everything I'm talking about today does not necessarily reflect the views of my institution, UT Southwestern. These are all my own personal views, and the pictures in this presentation are also mine unless otherwise noted. So today, the objectives of what I'm going to talk about is, first of all, lay a foundation for why we must rethink global health, particularly in the current climate that we're in, and then talk about 5 pillars for transformation, which include prevention, equity, resilience, innovation, communication, and then define the things that we can do as citizens and advocacy groups and people who are interested in healthcare to drive change. So before I get started, I'm going to set the stage for you. So in November 2024, I arrived in Sierra Leone. Sorry, not 2024, November 2014. I arrived in Sierra Leone to help with the Ebola response that was taking over West Africa. Late in the afternoon on my first day, I got called by the District Ebola Response Center that there was a 24-year-old pregnant woman who had no known stick contacts, who had abdominal pain and fever, that they wanted to admit to our Ebola treatment center. And so as we were getting ready and planning for her arrival, we quickly went around and gathered the bare minimal materials that we had. So pain medications, malaria medication, oral rehydration salts, and that was pretty much it. And it was getting late, and we didn't have any electricity at the treatment center, so we had to find headlamps that we could wear for light in the midst of wearing all this PPE that you can see in this picture. So the woman was transferred to our hospital, and she delivered a baby boy later that evening. And the next day, both the mother and the baby died. And the day after, we found out both of them were Ebola PCR positive. And I think that the reason I wanted to talk about this and give this example is you can see how fragile a healthcare system is. And when it's overtaken by a large outbreak like Ebola, as happened all over West Africa, it was one of the reasons why it was hard to contain this outbreak and why it went on for so long. And at the end of the outbreak, over 28,000 cases and 11,000 deaths occurred, mostly in Guinea, Liberia, and Sierra Leone. And this really exposed the gaps in preparedness, equity, and response coordination. And at that time, Dr. Margaret Chan, who was the Director General of WHO, in a way foreshadowed what was going to happen. She said very clearly that this outbreak was a wake-up call and that the world was ill-prepared to respond to outbreaks of infectious diseases. And as we found out a few years later, she was absolutely right. And so, quite simply, our current global health model, which is built largely on the 20th century foundations, is not equipped to meet the 21st century realities. And because of that, we must reimagine it to prioritize prevention, equality, resilience, innovation, and trust. So we need to understand a little bit about global health today. So global health is often described as aspirational in terms. We use terms like equity, solidarity, accountability, but in practice, the landscape is shaped by power imbalances. So we talk about healthcare being a human right, but really, access is shaped by your geography, your wealth, and by politics. We talk about global solidarity. However, as we saw during COVID, vaccine nationalism really drove the outbreak response with resource-rich countries hoarding vaccines. We talk about using evidence and equity centered on decision-making. However, in reality, funding priorities are driven by donor agendas and not local needs. We talk about having strong healthcare systems. However, we don't invest in frontline systems so they're ready to respond. And then we talk about timely and transparent communication. But in reality, as we've seen, especially over the last few years, misinformation spreads faster than facts. And so, when we talk about some of these examples, we talk about COVID, we talk about Mpox. Nobody was really paying attention to Mpox until the outbreak happened. And even still in 2022, when we had the outbreak, vaccines went to resource-rich countries. And we talk about capacity building, but like I said, the majority of the global health funding still goes to resource-rich countries. So, given this model, we need to think a little bit more about how we can change things. And in order to do that, we have to understand where are the global health organizations. So as you can see, this is a map that shows where global health organizations are located. And of 198 global organizations, a majority, 84%, are headquartered in Europe and North America. But that's not where they do the work. And greater than 80% of the leaders of these organizations are from the global north, so resource-rich countries. Yet they're doing the work in places like Africa, South America, and Asia. We also must understand who's leading. And so for the most part, it isn't the people in the countries that are most affected, but rather 65% of nonprofit seats are held by those in high-income countries, and 2% of board seats are occupied by women in lower middle-income countries. And then we must also understand where global health funding goes. And this is a very fluid situation right now, given everything that's going on in our country. But typically, some of the agencies we look at, like the Fogarty International Center, which is funded by the NIH, well, 70% of their grants go to US and high-income institutions. And these are the institutions that are doing work in the countries that are affected. Prior to the destruction of USAID, 80% of the contracts and grants went to US firms, not to firms in the countries that are being affected. Wellcome Trust, which is in the UK, most of their their awards go to, again, countries that are in the global north. And even the Bill and Melinda Gates Foundation, with all the great work that they do, almost 90% of their funding goes to institutions and organizations in the global north. So not to the areas that are really on the ground doing the work. So while I'm going to spend a lot of today reflecting on what needs to change in global health, it's important to recognize how far we've come. So smallpox, eradication is one of the most important things that has happened in my lifetime, and it was declared eradicated in 1980, and it was an historic public health achievement. I don't know that we'll ever see that again, given everything that's going on. We have had near eradication of polio since the Global Polio Eradication Initiative launched in 1988. Wild poliovirus cases have declined by over 99%, from 350,000 cases in 125 countries to just 12 cases in 2023. And in 2024, poliovirus type 1 was only found in Pakistan and Afghanistan. The COVID-19 response, one of the actual great successes of the response was that we demonstrated the power of rapid, globally coordinated science with vaccines developed in unprecedented speed, despite inequities in access. The HIV response, one of the most important acts that happened in my lifetime was the creation of PEPFAR by George W. Bush. And, previously we never thought we'd see a day where we could talk about people living with HIV for their life and not having to worry about getting infections related to their HIV. And now, because of PEPFAR, we were giving life-saving antiretroviral therapy to over 30 million people globally. And then, very importantly are the partnerships. So there have been many innovative partnerships from private public sector collaborations and regional institutions like Africa CDC. These are reshaping what's possible when it comes to financing, delivery, and governance. And these are not small wins. They demonstrate what can happen when we are all aligned and working together and cooperating together. And there is amazing progress that can happen. And so we now need to take the energy that we had in doing these things and move forward and trying to figure out how we can continue the work. So while global health has achieved much, it has also exposed very deep fractures. And as I will mention a couple of times in this talk, I think one of the greatest examples is the inequity of the COVID vaccine allocation. COVID starkly revealed that despite rapid scientific advances, equitable access really was elusive. And by mid-2022, less than 25% of persons in low-income countries had received one dose of COVID vaccines. Endemic diseases like Mpox and Ebola have been long neglected and viewed as distant problems in a place far off. But then we pay attention to them when they become global threats, rather than investing in helping to prevent these outbreaks from happening in the first place. Fragile health systems, particularly in resource-limited settings, have struggled to absorb the shocks from COVID-19, from Mpox, and some of the resurgence in infectious diseases we are now seeing. Many countries are unable to scale testing, have poor access to treatment or vaccinations, and this is really due to underfunding. Equally important is there's been a failure to center local voices, right? Global health initiatives are often driven by donor priorities, and those are not the people who are actively being affected by what is going on. And as I mentioned before, we've had slow responses to misinformation and disinformation, and this really has undermined public trust. Going, really as far back as, the H1N1 pandemic in 2009, we saw it more with Ebola in 2014, and then I think there's many examples of how this happened during COVID-19. And I think it's important to think about these things. So the future of global health will be shaped by interconnected crises, and we need to understand how global health has changed over the last 40 to 50 years. So number one, climate change. So it's not just an environmental issue, it is a health crisis that is already accelerating the spread of diseases. We are seeing outbreaks of dengue at record numbers. There's large outbreaks of chikungunya now. China has had over 7,000 cases reported in June. We are seeing malaria in places that we've never seen it before. Additionally, we are seeing rapid urbanization, and this creates environments ripe for respiratory infections and waterborne disease outbreaks. We are seeing human encroachment on wildlife habitats, and this increases the risk of zoonotic spillover, so infections from animal to humans, and then they propagate on into humans and are transmitted. And this is how novel pathogens emerge and spread. Additionally, conflict, migration, and fragility. So there are many conflict zones around the world right now, Gaza, Sudan, Ukraine, and the conflict there further compounds vulnerabilities and leaves millions without reliable health systems, and quietly also antimicrobial resistance. So this is something that's not really talked about much, but it's really called a silent pandemic. And it's estimated to cost over 39 million deaths by 2050 unless urgent action is taken. And I can tell you from personal experience, working in the hospital, it's not uncommon to see patients now who come in with infections that are almost resistant to all the antibiotics we have. And that is a really frightening and scary thing to think about. So reimagining global health must mean anticipating and not just reacting to these complex and overlapping threats. So we're really at a fork in the road right now when it comes to global health. We could maintain the status quo, which we've been doing for many years, or we could really think about how we take this time that we're in to change things and build a better and more sustainable system. So two of the core problems with the current global health model is that it's reactive in nature and embedded in inequities. We've seen this repeatedly, like I said, from Ebola to COVID to Mpox. We've seen that funding and attention often arrive after the crisis has developed, and even then it's given unevenly. Preparedness, especially in resource-limited settings, has remained chronically underfunded despite repeated warnings. You can see here, this is a picture from the Ebola treatment center that I worked at in Sierra Leone. And this is a health worker doffing biohazardous PPE next to a pile of biohazardous PPE. This is probably one of the most frightening things I saw, as this is a person who's in an ETU taking care of patients and doesn't even have a safe place to detox themselves after being in the ETU. Simultaneously, many communities most affected by outbreaks have had little voice in the design or governance of global health responses. And these failures are not incidental, they're structural. To move forward, we have to fundamentally rethink who sets the priorities, how decisions are made, and who benefits. So I've mentioned COVID-19 a couple of times, and I think we all know COVID-19 was devastating. It had a huge impact on the economy, it had a huge impact on healthcare and on the population. And some of the things that haven't been talked about are the broader impact of COVID. So, over 20 million plus estimated deaths. In terms of the economy, it was estimated that over 16 trillion revenue losses were had by international sectors. Over 1.6 billion students were displaced from school. We had huge setbacks when it came to investment in clean energy transition, and it's estimated that over 135 million people will be pushed into poverty by 2030. In addition, over 300 million people are in need of humanitarian assistance as a result of climate disasters and geopolitical crises. And the point of this is to also have you understand that, it's not just the pandemic when it's happening or the outbreak when it's happening, it's the long-term repercussions that it has that can go on for generations, and that's what we will see with COVID. So despite all the failures I've discussed, it's also a moment of profound possibility. The pandemic, for all its devastation, laid bare the urgency of building better systems and gave us tools and momentum to act. We're seeing a shift towards more equitable leadership, more regional innovation, and deeper conversation about power, justice, and sustainability in global health. It's up to us to decide if we're going to take this opportunity, and the next decade will determine whether we simply patch up the old system or build a new one designed for today's world. And as I mentioned, crises create momentum for change. So COVID-19, mpox, and climate-driven outbreaks have exposed systemic vulnerabilities and created the urgency to act. New tools, new voices, and new alliances are developing. One great example is the development of mRNA technology and regional leadership with Africa CDC and civil society to develop mRNA hubs in Africa so they're not reliant on those of us in the global north. There's a growing consensus on equity and preparedness and high-level commitment, such as the Pandemic Accord that was recently adopted by the World Health Association. They offer potential, but they need to be followed up by action. And we're seeing younger people also take leadership roles in global health. And that is an important thing for us to be seeing, because a lot of these are also people are coming from resource-limited countries and marginalized communities, and they're pushing to field a system that is based on justice and sustainability as well as equity. And like I said, reimagining is no longer optional. There's many things going on in the world today, and it's urgent that we have transformation now, but this window will not stay open forever. So I'm going to talk about 5 pillars for reimagining global health, and they are prevention, equity, resilience, innovation, and communication. So first, when I talk about prevention, so the idea that pandemics just happen is false. In almost every major outbreak, from SARS to Ebola to mpox, there were warning signs that were visible, that were missed, mainly because of underfunding and the fact that we ignored these warning signs. Mpox has been going on in Central Africa since the late 1970s, and cases were increasing there. And when we look back now, those were warning signs that this outbreak could have continued to expand. COVID-19, the same thing. We had outbreaks of SARS and MERS, and so there was concern that there'd be another novel coronavirus, and as we learned in 2020, that happened. So it's important to not ignore these warning signs. Additionally, prevention means that we prioritize systems, science, and people that can stop an outbreak before it starts. Analysis has showed that $1 in prevention saves $5 to $10 in response costs. So quite simply, prevention really is you get your bang for your buck. And this includes things like surveillance, developing strong primary care systems, environmental monitoring, and frontline public health workers. And you know, it's really interesting. We don't want to invest in preparedness, but when an outbreak happens, we are willing to invest billions of dollars. And had we taken that money and invested it early on, we could have actually saved money and lives. So if we want to reimagine global health, we have to reorient from a reactive system to one that is more proactive and puts prevention where it belongs. So one of the clearest lessons, particularly recently and from almost every major outbreak, is that we cannot just silo human health from animal and environmental health. Whether it's bats that cause Ebola, rope squirrels causing mpox, or deforestation disrupting ecosystems, most pandemics begin in places where humans interact with animals and their habitats. So taking a One Health approach is not something we can just consider, it's something that we have to do. And we know that over 70% of emerging diseases are zoonotic, meaning that they spill over from animal to humans. So it is important for us to think about human health and animal health together. We also must develop early warning systems that cut across ministries, sectors, and disciplines. And, you know, I think it's important to remember that most countries actually lack operational One Health frameworks. They also lack trained professionals and funding to be able to do this kind of work. However, if we need to stop the next outbreak, One Health must become the global norm and not the exception. And bringing that home even closer, you know, we've had cases of H5N1 in cattle here in Texas, throughout the United States, with intermittent cases in farm workers. And it's a perfect example of how infectious diseases can spill over from animals to humans. And the concern is that as we have continued spread of these viruses, is that the virus can continue to adapt and then become more suitable for the human host, and thereby leading to more severe disease. So prevention is really multifaceted. So Africa CDC is aiming to produce 60% of its vaccines locally by 2040, and that's a significant step on self-reliance. The establishment of mRNA technology hubs like Afrigen in South Africa exemplifies innovation in building regional capacity. However, vaccines alone aren't enough. We need comprehensive structure, including the development of diagnostics and trained personnel who can use those diagnostics. Additionally, successful mass vaccination campaigns. So for an example of this is mass yellow fever campaigns in West Africa have immunized over 60 million people, reducing the risk of outbreaks. And to truly prevent outbreaks, we must invest in integrated systems that encompass all aspects of health preparedness. So diagnostics, PPE, having a skilled workforce, having cold chain systems that are critical for readiness, and also having integrated systems. So where we're working with government sectors, finance sectors, and also with community engagement. The next pillar that I'm going to talk about is equity. So equity is often framed as generosity, but it's not about giving. It's about making sure every person has fundamental human rights. Having fair access to prevention, care, and innovation, regardless of where you live. And remembering that health, in fact, is a human right. It's not a privilege, it's a right. And many people who lack access to essential services and medicines, not just in the US, but around the world. Global health has long been shaped by a top-down model in which funding flows from wealthy nations and decisions follow. But this framework reinforces dependency and ignores the local context. And, not to get political, but a lot of the things that have been happening recently show why this type of model is unsustainable. The destruction of USAID put many of my colleagues in other countries that were relying on that money out of work and has had far-reaching implications. So we need to develop a framework that is more sustainable. True equity means communities and countries can access prevention, they can access care, and they have access to innovation, such as innovative technology, like mRNA technology, like diagnostics that are being developed. And they don't rely on quote-unquote handouts. And it also means that they have a seat at the table and the power to lead. So in reimagining global health, we must move beyond token involvement of partners in the global south and towards real shared decision-making. And that really will happen as we change the structures of funding, leadership, and accountability. And so, like we've talked about, the current global health architecture is inequitable by design. Many programs are built on short-term donor priorities rather than long-term local needs. And aid is often tied to visibility and politics rather than evidence. And where there's brilliant scientific and public health expertise in the global south, these people are often frequently excluded from authorship, from strategy decisions, or governance. And like I said, we've seen this repeatedly. So I'm only going back, over the last 10 to 15 years, but if we go further back in time, we can see it, going all the way back to different outbreaks. But like I said, during COVID, countries like Africa, Asia, and Latin America waited for months to get vaccines and diagnostics, while people in the United States and Europe had access to them almost immediately. And these delays cost lives. And during the 2014 Ebola outbreak, the world really did not pay attention to this outbreak until we had a case here in Texas, and we had some healthcare workers that had to be re-evacuated back to the United States. But this outbreak had been going on for about 9 months before it was really paid attention to in the United States. So if global health is to be credible, we must ensure that those closest to the problem are also central to the solution. So what does empowerment look like? So it looks like regional institutions, like I said, like Africa CDC, the Pan American Health Organization, really taking leadership roles and being resourced and trusted to lead responses. It looks like funders shifting from project-based grants to direct sustained funding of ministries of health, universities, and civil society organizations, particularly in the areas that are most affected. It also shows up in who's asked to write, speak, and decide. So making sure we have authorship and governance for people who are affected by what's going on, and also having communities lead. So not just those that have historically been at the forefront, but also those that have been historically marginalized. And this is something that we really did when I was at WHO during the Mpox outbreak, is really making sure that we had the persons who were most likely to be affected by the outbreak coming forward and speaking, talking about their experiences. And they were really able to be very helpful as we developed a plan and a strategy for how to address and contain the outbreak. So, like I said, I've talked a lot about COVID-19, but there's a lot of lessons to be learned. And COVID-19 was really the mirror that reflected back the values of the global health system. And in many ways, we really did fail the equity test. So, as I've talked about, high-income countries really hoarded vaccines. They pre-ordered 70% of the vaccines, leaving lower-income countries with long delays. Even initiatives like COVAX, which was developed by WHO, while well-intentioned, struggled to deliver because they lacked the leverage and manufacturing capacity, and was really based on quote-unquote generosity of high-income countries. And, you know, I think a perfect example of this, and something that my colleagues in Africa are trying to change, is that Africa has largely been reliant on other countries for their vaccines. In 2021, they imported over 99% of their vaccines. And for them, that level of sustainability, that level of dependency is not sustainable. And when they have that, what's happening is that it's leading to delays in vaccination. And so here in this map, you can see this is a map from December of 2023 showing what percentage of the population was vaccinated with at least one dose of COVID-19 vaccine. And what stands out to me is really Africa. So the lighter color shows less of the population vaccinated. And they really, were not able to get people vaccinated because of all the things that we've talked about. And as a result, more people got sick, more people died, and more people are now living with long COVID. So the consequences are just moral. They have long-term effects on populations, and we say this term quite often, that no one is safe until everyone is safe, and that's true whether we're talking about COVID or, an outbreak happening in the middle of another country. We need to make sure everybody has access to the available tools that we have. Okay, and then the next thing I'm going to talk about is resilience. So building resilient health systems is important. They don't just bounce back after emergencies, they prevent emergencies from happening in the first place. Universal health coverage ensures that health isn't just for the privileged, it's for everyone, and it allows people to access care early. Additionally, developing infrastructure like labs, surveillance, and supply chains are important so they can scale up during crises. And then finally, having public trust in the health systems so people feel comfortable going to the health system when they are sick is important as well. So why do health systems fail during crises? It's usually not due to lack of commitment, it's due to lack of funding, workforce issues, the fragility of the system, and fragmentation. Too many countries are trying to build a 21st century system with 20th century resources. If we don't have the basic public health capacities, or we don't have an agile workforce, that means that we're not going to be able to respond to these threats in a timely manner. And so the goal is to not have parallel systems for emergencies, but to have a stronger system overall. So health workers are really the backbone of resilience. and it's important that we invest in them. WHO projects that there will be a global shortage of about 10 million health workers by 2030. It is difficult to retain health workers, especially in resource-limited settings due to poor pay, lack of professional development, and safety issues. We need to be training health workers, and that requires them to not just be trained in recognizing a disease, but also in things like infection prevention and control, so they can protect themselves and other people that they work with, surveillance systems to rapidly detect outbreaks, and clinical management. And then finally, community health workers that are often forgotten. They are vital links in the work that we do between systems and populations, but they are also often unpaid and unsupported. And that, can be a problem. When I was working in West Africa during the Ebola outbreak, we worked with a lot of community health workers, and they had trouble just getting them the money they needed to be paid, and would go on strike, and that would severely affect many other aspects of the response. So it's important that we have all aspects of our healthcare system feeling supported and ready to go and protected. And I think an example that I wanted to give of resilience was actually the recent outbreak from Marburg virus in Rwanda. And if you don't know what Marburg is, it's a virus that's very similar to Ebola. And what Rwanda did was really actually quite remarkable. So after the 1994 genocide, they rebuilt their health system and really focused on having an equitable health system. They have a community health insurance system that covers over 90% of their population. So as a result of having this strong health system, when the first cases of Marburg were detected, they were identified and confirmed quickly in Rwanda within days, and they were quickly able to stand up their outbreak response and developed and implemented their containment protocols. They have a strong community-based response, and this was led by local health workers who led things like contact tracing, risk communication, so population was aware of what was going on, and they were able to leverage the trust that they had already built over the last 20 to 30 years. Additionally, there were plans in place for national coordination, and they activated their emergency response framework and worked with local, regional, and international partners to quickly contain the outbreak. And what happened was, because of that, they were also able to have effective case management. They were able to quickly implement vaccination and ring vaccination, so the outbreak did not spread. And they were able to contain this outbreak in record time. And it was really an example of what can happen when you have a strong healthcare system that is ready to go when these threats emerge. So the fourth pillar I'm going to talk about is innovation, and innovation is important. It's not just about developing things, it's also getting it to the point where it's delivered and available to all. So scientific innovation is really important. We have these powerful tools now, like mRNA vaccines, which are not just used for infectious diseases, but are being developed for things like cancer. We have artificial intelligence, we have genomic sequencing, and those things are really great, but they have to be available to all people. And it's not just developing it, it's also application. So how do we deploy these innovations to help contain outbreaks quicker and faster? How do we use medical countermeasures in a more effective way? It's also making sure that we have real-time surveillance and reporting to inform rapid response and resource allocation, and also using mobile tools like telemedicine to bring care to people in remote areas. And I think, a great example of this is during COVID is there were many people, not just here in the United States, in rural areas, but in other countries that didn't have access to physicians that knew how to take care of patients with COVID. And there are lots of really innovative telemedicine platforms that were developed, so people who did have the expertise could help people in areas that didn't have that expertise, so they could receive the care that they needed to survive. So, innovation looks like lots of different things. It's not just developing medicines. So some examples of innovation is the development of GISAID. So GISAID is an influenza surveillance network that has been in place for many years. And during the early days of COVID, researchers started uploading the sequences for SARS-CoV-2 onto GISAID. And not only does this help in developing the mRNA vaccine, it also helped us quickly detect new variants of SARS-CoV-2. And as we were able to detect and understand them, we were able to provide information to the public about what was going on. I've talked about mRNA technology. I think once, it was thought of being this experimental thing, and now there's lots of real promise with mRNA technology, not just for COVID, but for influenza, for Mpox, for H5N1, for cancer. There's lots of broad applications of this technology. And then another really important example of innovation is the development of rapid diagnostics. This can improve detection of cases and access. And so, I think some examples I'm going to use from Ebola. When I was first there, we used to have to send our samples about 5 hours away for them to do testing, and it would take, anywhere from 3 to 4, actually longer than that, probably usually about, a week to get results back. Whereas as the outbreak went on, we had point of care tests for Ebola, and we were able to do those testings right where we were, so we would know if patients were infected or not. And that has a lot of downstream repercussions, not just for the management of patients, but also, how we isolate patients in Ebola treatment centers. So innovation is important, but it matters because if it reaches everyone, and we need to make sure that it reaches everyone. So why does innovation fail to reach the front lines? So it doesn't fail because science is flawed. It fails because the system isn't built for equitable delivery. From restrictions on intellectual property to missing cold chains, the barriers are really systematic. So if we want to ensure that innovation improves health globally, we have to break down the barriers early and not just during crises. I'm going to skip that for time. And then the last pillar I'm going to talk about is communication. So health really begins with communications and with communities. We often think of medicine and vaccines as our powerful tools, but trust is probably the most important thing that we have. People are more likely to follow guidance when they trust health systems and messengers. We have seen in many different settings that mistrust fuels outbreaks because people are resistant to getting care. We see delayed reporting. We see poor uptake of interventions that can prevent spread. And we've learned that transparent communication builds credibility. So public confidence increases when authorities acknowledge uncertainty and update information on a regular basis. And I think that one of the challenges with COVID was, while we talked about what we knew, we didn't do a great job of talking about what we didn't know. And I think as time went on, we learned that it probably would have been better to also talk about what we didn't know, and having that acknowledgement that we didn't know everything may have actually helped build better trust in the long run. And then also having culturally appropriate messaging. So having messaging in local languages and formats and with voices that are trusted. So what might work here in the United States may not work in Asia or may not work in Africa. So tailoring your communication and tailoring who's communicating that information, I think, is really important. So some of the challenges in health communication is really misinformation is a huge problem. And as I said before, fiction spreads faster than facts. And it leads to people losing their lives. We saw during COVID and Mpox just how rumors outpaced facts, leading to vaccine refusal, stigma, and fear. And so to address this, we really need to have both a rapid response and a long-term investment in health literacy and also trust building. Some of the principles of effective communication, so there's not a one-size-fits-all when it comes to communication, but the best messages come from people who those in the community know, in languages that they understand, and are appropriate for the communities that they are addressing. And we need to shift from a top-down messaging system to a two-way dialogue where we really engage with communities that are affected and also understand what their concerns are. That also helps in developing trust and empowerment. I'm going to skip that. Sorry, because I realize I'm almost at time. So how do we make these pillars work? So these 5 pillars are more than ideals. They need infrastructure, funding, and enforceable commitment. The pandemic agreement, which was ratified by the World Health Assembly in May, provides a chance to codify the world that we want, one where data is shared, vaccines are accessible, and systems are ready. And this is not theoretical. And it is probably the clearest example right now that we have of how we can reimagine global health and make it real. So what can we all do? So we all have a very important role. We are people that can communicate, we are advocates, we are stewards of the health systems, we can engage in policy, research, and communication. And it's important to remember that leadership can be at every level, from local health departments to global agencies. Influence can really happen everywhere. And it's important that we have humility and collaboration and justice. This will build lasting partnerships in the long run. And I've spent the hour talking about what needs to change, but now it's time to decide the role that we all want to take. And change doesn't just require a title, it requires courage. Whether you're writing policy, whether you're running a clinic, whether you're an advocate, whether you're conducting research or teaching, we are all part of this movement. And we can lead, and we can make sure that we develop partnerships that are sustainable over the long run across sectors and across disciplines. So just to highlight, when we talk about reimagining global health, we talk about prevention and having systems that prioritize upstream investment and preparedness, access, ensuring innovations are shared from where they're developed to the front line, equity, ensuring inclusion is the standard, and having trust and building trust through transparency and inclusion. So, in conclusion, this new era of climate threats, misinformation, and inequity demands a stronger, fairer global health system. We must prioritize preparedness over crisis-driven responses. And prevention, equity, resilience, innovation, and trust are essential pillars of a healthier world. We all have a role in building a fairer, stronger global health system, and your voice, your leadership, and your action are part of this transformation. And I'm going to end with this quote from my former boss, and I think it's very telling. Failing to prepare for a pandemic is preparing to fail humanity. And I really do believe that. I think if we're not prepared for what is going to come next, we are going to be in a world of trouble. And we need to think about how we can do that given where we are today. And with that, I'm going to end. Just thank you to some people that I work with that have been huge inspiration for me. And this is a picture outside of WHO where I was working before I moved to Texas. And this is a very famous statue, really trying to exemplify the importance of health for all. So thank you.
Thank you so much. I think you've been telling us something we all, I'm speaking for everyone here, agree with wholeheartedly. Do I hear yes?
It's great to hear that.
So you are singing to the choir and you sang beautifully. Thank you so much. Our role in this is trying to get Congress to appropriate the funds. And our focus right now is on getting Gavi funded as generously as possible, getting the global fund to fight AIDS, TB, and malaria funded as generously as possible, having adequate funding for tuberculosis, maternal health, child nutrition. Those are pretty much our 4 priorities for global health. And so we meet with members of Congress and try to persuade them to do that. And one of the meetings we had this year was with Senator Ted Cruz's foreign policy aide, Madison Sparber. And I never thought I'd say this, but that was the most positive meeting I had all year by her response and his inclination on this. And one of the things that he's on the Senate Foreign Relations Committee, and he's on the Africa Subcommittee. So he's ideally placed to make a huge difference in this. So just giving you a sense of who we are and what our contribution is, we are going to fight and hard as we possibly can to get this funding secured and improved and at least held steady. That's what we want to do for this year, just not slip backwards. We're very encouraged by what the House Appropriations Committee recently marked up and released. I'm sure you're familiar with that. And but one of my questions that's aside from that is, you talked about organizations that are inclusive, that are including the voices of those most effective. Are there any organizations, institutions, countries that you see as leading the way in that?
I mean, yeah, so thank you for the background. And, you know, there are certain countries that are really leading the way. I think the ones that, like I highlighted a little bit about what happened in Rwanda and during the Marburg outbreak, and I think that they're doing a great job. I think South Africa, Uganda, India, right? Like there are lots of other countries out there that are trying to do that. And I think it's important because one thing that I have learned from everything that I've done and also my interactions with particularly US government and funders is that they really respond to real on the ground stories. Like when you can tell them like this personal story about something that happened with a patient, something that you dealt with, it makes a powerful impact on them. And then I think that that makes them more likely to go to bat for the things that we're talking about. And so I do think, you know, all the great work you all are doing is wonderful. I think one way to, and I don't know if you are doing this, but I think one way to potentially strengthen it is to get the voices of people in those countries.
Right, maybe you can help us with that. You have a network.
I do. Yes, I do.
And
yes.
One of the things I've been trying to do is reach out to USAID, all the people who've been let go, who have direct experience in this and can help us tell those stories. And so I want to tell you that we are open to including people in the meetings we have, and we have meetings all the time with members of Congress and their staff, either in person or virtually. And so we can partner with you in our shared goal to make the world a more equitable and healthy place.
Yeah, I would love to. I think it's really important, you know, and like I said, I mean, I remember back, I mean, I've done this twice now, well, I've done it a couple of times, but like when I came back from West Africa and had been on the front line taking care of patients with Ebola, I ended up, you know, talking to members of Congress and explaining to them, right, like what we're seeing, what we're dealing with, why investment is important. And I think, again, those stories are very powerful for them. And, you know, even, you know, giving them information, a lot of times they don't know what they don't know. So beginning of COVID, when we were all trying to figure out what's going on, I did a congressional briefing just to give them information about what was going on. And I think those types of things are helpful. Even with the things going on in the US today, right? We have measles, we have H5N1, we have worsening antimicrobial resistance, record numbers of STI cases, TB, malaria, HIV, all those things. But I found that, you know, taking that kind of approach is really helpful and can really help garner a advocate in the leadership.
Yeah, we're very open to that. One of the members of my group is a native of Zimbabwe. And in the meeting with Senator Cruz's foreign policy aide, she told the story of her sister dying from an infectious disease in Zimbabwe, which was powerful and meaningful.
Right.
So we are doing that as best we can. So we could use some help in spreading our network and letting people know that we have access, we have relationships, we get meetings with members of Congress that other people in our coalition partners aren't able to get. We've been doing this for 45 years. So we are good at this. We know what we're doing, and but we'd love to have some more stories and experience and people accompanying you, like yourself, to these meetings we have with people who actually make the decisions. So let's take a few more minutes, even though we're at time, because I know other people are going to want to make some comments. They're going to gripe at me if I would hog this all to myself.
Sure. Happy to take questions.
Yes, so, hi. My name is Babita. I'm a volunteer with the Fort Worth Results. And my member of Congress, my representative, is Brandon Gill. He is freshman representative, just got elected recently. So he sends out newsletters saying, he co-sponsored the bill to do away with USAID. So if I have a congressperson who is wanting to do away with USAID, what from your expertise could we do to bring him along to either keep it, or what would be the replacement? Like, I need to know, or what we could propose. What do you think?
Yeah, I mean, I think, again, I think that engagement and providing personal stories are really impactful and helpful. I think that there's so much misinformation, not just about USAID, but a lot of these types of organizations or agencies that fund this kind of work, and they don't really understand the real on-the-ground impact that they have. And I think those are ways to get people to kind of continue along the journey with you. So that's what I would say. Does that answer your question? Okay.
Because I was looking for more concrete items to provide to this office. Hey, I know this congressman is wanting to do away with USAID altogether. So in that case, if USAID didn't exist in the very near future completely, what would you say?
If USAID didn't exist?
Yeah, because that's what he wants to do.
Well, USAID doesn't exist anymore, right? So, I think it's talking to them about the ways that U.S. funding has been helpful to different places, but also talking about, unfortunately, we're in a situation where people really care about, how does this affect the United States? How is this going to affect us, right? So I think also talking to them about, it is in our interest to help these other countries that are dealing with these outbreaks, because we don't want them spreading and we don't want them coming here, right? And I think it's almost kind of like a reverse psychology type of situation, and trying to approach it from a way that is that is palatable for them. I don't know if that helps a little bit.
Hello, so my name is Zodwa, and I'm a volunteer with the Dallas group and used to volunteer with the DFW group. I think my question is almost what Babita is asking. So when you presented about the USAID, the funding, most of the funding was 80% into the American companies, is that what you said? And also Melinda Gates, the funding is really funding the groups that are here. What I want to hear from you is that when you are reimagining this global health, how would you want it to be allocated in the future, as we know that this has been dismantled, as we are creating and thinking about the future, how we can build this new model? How would you think that the funding needs to be to actually reach the places that it's supposed to empower?
Okay, I just want to make sure I understood the question. I'm having a hard time hearing you. So you're asking how we can reallocate funding? Is that the question? Okay.
Yes.
So yeah, I think that there's lots of ways we can reallocate funding, in particular to the areas that are actually doing the work, right? So right now, the way funding happens is, I'm sitting here in Texas. I write a grant to do Mpox research in Africa, right? And there's a sub-award that goes to my researcher or colleagues there. I think the better approach is directly funding them, so they are able to, because they understand better what's going on, but there's not a lot of opportunities for them to get that kind of funding, which is why they have to partner with people in the US or in Europe, because those, a lot of the grants in the United States are really open to people from the United States. And to an extent that makes sense, but we have to be able to more easily fund people in the country that are doing the work, because they really understand what the priorities are. Does that answer the question?
Yes.
Okay.
Yes, thank you.
All right, thank you very much.
Thank you. Thank you.